Okay, welcome to The Whole Itself Remains. I'm your host, Todd Caldecott, and you're listening to CJMP Co-op Radio 90.1 FM, broadcasting from the qathet region on the beautiful Sunshine Coast of British Columbia, on the traditional territory of the Tla'amin people. This show is part of a weekly Q&A series where subscribers join me each Wednesday to explore health, healing, and human wholeness. And then after the broadcast, we dive deeper into a 30 to 60-minute Q&A where subscribers can ask me anything, clinical, personal, even philosophical. Now, if you're tuning in on CJMP or watching later on YouTube and you want to join the live conversation, the Q&A, stay with me and I'll explain how to do so at the end of the show. So we're going to pick up from where we left off last week. And I know we continued in part some of this discussion in the Q&A, but because listeners don't necessarily have that benefit, I want to pick up from there. So last week it was an introduction to holism. I talked a little bit about my personal experience with the topic, how I got into it, and I definitely don't want to make this about me, and so I won't be spending a lot of time talking about me in this podcast series. But at least as a frame of reference, it gives you a little bit of background about where I'm coming from. And then we kind of delved into some basic definitions about what holism is and understanding its roots within Greek philosophy. And we left off with a discussion of the father of metaphysics, the Greek philosopher Parmenides, and his poem on nature, which describes two fundamental forms of perception, one called aletheia or truth, and the other is doxa or opinion. And we exist primarily in this world of doxa or opinion, in contrast to this perception of aletheia. So for Parmenides, and generally whenever we're speaking logically of something that is true does not change, right? Like if you're asking someone a question to something and you're trying to get the truth and they give you one answer and you accept it as truth, but then you find out later on that that answer has changed, then that answer wasn't true. It might be temporally true, but because we live in this changing reality, it's not fundamentally true. And I think we all kind of understand that. Uh, when we talk about facts in science, we're often talking about theses which have been proved, but there isn't like incontrovertible proof that extends over an extended duration of time that will define that as being true. You think about all the fundamental laws of the universe that we've discovered as humans. Conceivably, there was a time, if we accept the Big Bang Theory, where those fundamental laws did not exist. And because of the nature of that theory, the sort of pulse-like nature of the universe, that it arose from a singularity that gave birth to the universe and then will eventually collapse in upon itself again, that these fundamental laws did not exist, and in the future, some distant point in the future, almost like an infinity for us, uh, also will no longer exist. And so while we can say that they are temporally true and maybe seemingly infinitely true because of the limitations of our own individualized existence and the fact that humanity's only been around for, at most a few 100,000 years, that they seem like they're true, but they're not fundamentally true. We can understand that they have a beginning, a middle, and an end. And so this poses some philosophical problems for us, because then how do we ascertain or determine whether or not something is true? And so this is a part of something that I want to probe and understand and help us understand how to apply these holistic principles in the context of, say, a clinical practice or just our everyday life. So we talked about Parmenides in this dichotomy between aletheia and doxa, of truth and opinion, that we exist in this world of opinion, this world of continuous change. I likened it also to the Buddhist conception of dukkha, which means suffering. When we think about the Buddhist principles, we think about this word suffering, we can all relate to the nature of suffering. It could be trauma or loss. We all go through it to one degree or another. But when we probe more deeply into what the Buddha meant about suffering, it was more related to this notion of change. Because we have this expectation of things being true. And then, of course, we're continuously disappointed by the fact that those things are not fundamentally true and or that they change. It could be like a long-term relationship that you're in with someone for 20, 25 years, and then one day it's over. I'm not saying that always happens, but it can happen. It can be very shocking. And so we live in this world of continuous change. And for the Buddha, this was the point of friction, that the world does not match our expectations. So even though, we have well-laid plans and we account for all these different factors, I mean, sometimes whatever we do goes off without a hitch. And it's usually kind of surprising, especially if you've spent some time on this planet and you realize how often things don't go according to plan. It can be a very pleasant surprise. But the reality is that we plan for all these different contingencies because we know that things often don't go according to the plan. There are all these unknown unknowns that we have to account for. And this can create a lot of unsurety for us, a lot of problems in terms of how we move forward in the world. So as I said, as we can relate to the fact that suffering does happen, the root of that suffering is related to the nature of change and our expectations. This is what the Buddha meant when he talked about this fundamental feature of dukkha. So Parmenides is incredibly influential, and he gave rise to a lineage of Greek philosophers. His primary and most celebrated student, of course, was Socrates, and Socrates venerated his teacher, but his focus, as far as we know, was different. Socrates was more interested in the issues of ethics and dialectics, so argumentation and how to understand through argumentation and logical analysis if something is valid or invalid. And he had a profound effect on his students, of which the most prominent was Plato. And Plato took those teachings a step further and was more concerned with the application of ideals in the real world, and created a very hierarchical model of the world and how to understand it, and had important implications for governance and society, but was really rooted in kind of an idealistic concept of taking an abstract ideal that was an intellectual exercise and then applying that to everyday life. Aristotle, Plato's student, uh, took a very different tact. He didn't agree with Plato's understanding of philosophy per se. He was more interested in empiricism. He was more interested in not applying maybe these abstract disembodied ideals to the real world, but to study the real world itself, and from that formulate a hypothesis, an understanding of how that world exists. And so, to some extent, Aristotle in his approach to philosophy was kind of a revolution. Now, the fundamental teaching that Aristotle applied is rooted in something called the three laws of thought. And of these different laws, it's really the first one that is the most important, and the subsequent laws, the other two laws, are dependent upon the first. So we'll spend some time talking about the first because it is most important. And essentially, the thesis behind it can be expressed mathematically as A equals A, which is to say that if you can describe some discrete identity, for example, if you're talking about a chair and you call that a chair, then that chair is a chair. It's not a cow, it's not a tree, it's not the sun, it's not a person that you know, it is a chair. And so this law of identity is very important when we talk about logic, because it helps us to understand and define the terms of that investigation or that argument. So you can understand that if you're having a discussion with somebody and you can't agree on basic terms, like even if it's just like can you pass me my keys over there? And they come back and they give you a banana. You're like, no, no, I said the keys. And then they go and they come back and they give you a frying pan. You're like, no, like keys. Like we have to have an understanding of some basic common use of these different terms. And that is the application of Aristotle's law of identity. It's obviously very important. It'd be very hard to get by in this world if we didn't agree on this fundamental law of logic, the law of identity. Now, the challenge with it, of course, is that it doesn't necessarily define the nature of our reality, and it is rather a logical device. So, for example, that chair that we described, we say that chair is a chair. Well, right now, temporally, it is a chair. But if we look over a duration of time, we will understand that prior to being a chair, that chair was a tree growing in a forest somewhere. And then if we extend forward maybe 100 years, that chair is now the glowing embers in a fire, right? So that chair exists in a state of temporality, meaning that it changes over time. It's still dependent upon what Parmenides called doxa, this world of change in opinion. And so we need to understand that when Aristotle expresses this law of identity, it represents just a temporal reality, not a fundamental truth. And that's really important to separate them out because we need a working model of this changing universe so that we can understand it. And we need it to be adaptable and flexible to the reality in which we live. Even if it doesn't express a fundamental truth, it still helps us. And it's easy to see, however, though, that when we take that law of identity as a function of fundamental truth, which I think many people do, and has found its way into philosophy and science, that it reinforces a worldview of separation and hierarchy. So let's talk about maybe something as slippery a topic as gender. So we'll say, okay, that there's two biological genders. There's male and there's female. And, we're dealing with this in society now. But the reality is, of course, is that the biological gender, apart from the psychological aspect of gender, can be expressed within a spectrum. On one side, you've got like your prototypical male, maximal testosterone secretion. They have all the characteristics and features of being a muscular, hairy man, embodying that quality of maleness. And then on the other side, you have a female who expresses all those fundamental aspects or qualities that we associate with being feminine. And those represent kind of two extremes. But then we know that within that spectrum, we all know that people exist somewhere, not necessarily at those polar opposites. So then we find men that aren't quite as masculine, and we find women that aren't quite as feminine, all the way until they kind of meet in the middle. And that occurs both on a psychological basis, i.e., that the way we experience reality as individuals doesn't necessarily conform to our biological gender. I mean, this is what we call gender dysphoria. And I think many people feel this way, even people that don't claim to have any kind of radical understanding or perception of their own gender. If you're a man, for example, you might feel that you're not as masculine as you could be. So, you work out, you take protein shakes, you watch, crypto bro podcasts, whatever it is to make yourself feel more masculine. And likewise on the opposite end of the spectrum, maybe as a woman, you don't feel you've got, the same physical dimensions of that prototypical woman. You haven't got the big boobs or the big hips or whatever it is that you associate with femininity. You're somewhere else on that spectrum. So even if you're just sort of heteronormative in terms of your understanding of gender, you probably find that there's some degree of gender dysphoria. That's why many women will put on makeup before they go out, right? And because they want to appear more feminine. So yeah, even something as distinct as gender obviously can be something that's more subtle in terms of our understanding. And especially even we're talking about it from a biological perspective. Think about people who are intersexed, who have characteristics and qualities of both biological sexes, reflected in the genetics in which they express. So that's something that we need to consider, that this is where Aristotle's law of identity begins to break down. And when applied rigorously, universally, tells us a mistruth, which is to say that it mischaracterizes the reality of the situation, the complexity of the situation, in favor of a very simple application of this logical principle of this law of identity. So while useful temporally to discuss things and to get clear on terms, if we apply it more universally, we understand that the law of identity, the way it separates things into neat little camps, that it doesn't actually reflect the reality in which we live. And when we look at the influence of the different Greek philosophers, I mean, very few people have heard of Parmenides, but many people have heard of Socrates and Plato. But the most important philosopher is Aristotle. And it was primarily because the teachings of Aristotle and the type of logical hierarchies that he imposed in his worldview, which are important for understanding the world, were adopted by the Christian Catholic Church. And this had a profound impact on the development of religion and spirituality in the Western world, and is something that we're still kind of contending with or dealing with today. So I wouldn't say that Christianity completely accepted everything about Aristotle. It adopted and modified aspects of his logic. It emphasized this notion of divine transcendence, so that there is a God which is separate from you, separate from me, separate from all of us. And then through these logical impositions, created a hierarchy that existed between you as an individual and this divine experience. And it's interesting because it directly contradicts the original teachings of Jesus. You know, Jesus was all about a direct connection with the divine. There's a quote in the Bible where, and this is paraphrasing, and I'm not a biblical scholar, but it's a paraphrasing where Jesus says, "Don't let anyone put themselves between you and God. Don't let anyone call themselves Father, because there's only one Father, and that Father is in heaven." And yet, as we can see with the Catholic Church and the development of all these different hierarchies, that there are all these intermediaries that exist between the experiencer of the religion and the divinity of it itself, whether it's a priest or it's a bishop, a cardinal, a pope. You know, it's a very complex hierarchy that gets applied, creating this sense of separation and what I'll describe as a disconnection. And other religions have kind of found a way around that. Islam does that to some extent, but also has its own intermediaries and complexities that can create some degree of separation. I think most religions do that in some fashion, create this set of intermediaries that separate you from this transcendental truth. So this was a really important function within Western society and shaped Western thought. So the Catholic Church adopted this logical hierarchies, this law of identity expressed by Aristotle, incorporated it into its religious or spiritual philosophy. And then when things began to shift during the Renaissance, when Europeans, after existing 1,000 years of essential darkness, where formerly the enlightened teachings of the Romans and the Greeks were just basically kind of a dead tradition, just copied in texts, from generation to generation without much uh, innovation or application of thought. Like you think about like texts like the medical text De Simplicibus by the Roman physician Galen. This was used for 1,000 years in Europe as the primary medical text. I mean, it's sort of amazing to think, especially nowadays when things change so quickly, that was the most eminent medical text for 1,000 years without any innovation. And so during the Renaissance, when people began to rediscover firsthand the teachings of the Greeks and the Romans and began to innovate their own ideas, uh, some of this, some of the church's doctrine and exclusivity began to break down. We saw this correlating with changes that happened in human health and disease. It began with the plague, where we had this infectious disease that spread across Europe. It was in large part a manifestation of improper sanitation, right? Like European cities that grew rapidly didn't have the same type of appreciation and understanding for sanitation and hygiene as the Roman empires did. And so, they would dig wells near graveyards and, they didn't have proper sewage, so they would just throw sewage into the middle of the street and people would march around in their shoes and then go inside. They didn't have this tradition as they did in the Eastern world where you take your shoes off before you go in the house. So you just walk around, mucking up the inside of the house with your, mucky boots. And this is where the role of strewing herbs comes from, which is that you would take medicinal herbs like rosemary, basil, thyme, and they were just sort of thrown onto the floor to keep down infection, right? While you walk around in your contaminated shoes. Now, we could, question that as a very, whether or not that's a very effective approach. I would suggest that it's not. It's not to impugn the benefits of medicinal plants, but, we have to wisely apply these preventative measures. And that's not something that was being undertaken. And so as a result, there was a big change that happened in terms of human health and disease and how we understood it in Europe, beginning with the plague, because the traditional herbal therapies, like throwing down strewing herbs or taking a herbal infusion or decoction to treat some problem, they weren't effective because they weren't dealing with the fundamental issue. And so there was a crisis of confidence in herbal medicine, the way it was being applied in this very kind of archaic way without much innovation or understanding. So it kind of fell apart and it gave rise to a new understanding of human health and disease that was the beginning of modern medicine. And, modern medicine, of course, as it evolved in opposition to it, was very simplistic in its understanding. Like the big innovation in Western medicine around that time was the discovery of the vascular system. The fact that there was a heart and that there were arteries and veins. This was like the number one innovative understanding about the human body. It's something that probably most, grade schoolers understand now about the human body. That was the cutting edge science of the day. And so, of course, all these different therapies and ideas around controlling or manipulating the vascular system were the most important interventions. But they were sort of disconnected from the 1,500 years of humoral medicine that had been applied by the church, drawn from the Greco-Roman tradition. Even though this advent of science that arose out of the confusion and inefficiencies of the humoral system and the old philosophy of the Greco-Romans, even though it existed in opposition, it still was a product of that culture and so incorporated many of the same logical principles employed by the Catholic Church. The whole notion of Aristotle's law of identity of A equals A was still a very important component of science moving forward. And moreover, the church's emphasis on hierarchy was also really important in the application of science. For example, the science of taxonomy, the way we organize and classify living beings, is itself derived from that hierarchical imposition that was employed by the Catholic Church. Right? So the way we describe different taxa and their interrelationship is a hierarchical model. that is derived from the essential thinking of the Catholic Church. And it's useful. I don't mean to say that it's not useful or applicable. Just like you look at many of the things that evolve within the church, there's an enormous wealth of knowledge and benefit there for sure. It's just whether or not it meets the actual needs of the person experiencing that religion as it relates to their capacity to connect with divinity. Likewise, the logical principles derived from Aristotle, influenced by the Catholic Church, incorporated into science, incredibly powerful, but is it an accurate representation of reality itself? And if it's not, what are the unintended consequences of applying that knowledge? And I think we have some answers there. I think we know what the answers are. Using these logical principles has definitely empowered science, has definitely given us more insight and knowledge into something. But it's essentially a reductionist model. And in medicine, this has really big implications, right? So we all should be familiar with the reductionist model. You look at something, you want to understand it, you break it down into its supposed constituent parts, and it gives you an insight into what that substance is. Then, of course, you can look at any of those constituent parts. You can look at any one of them individually, break them down into their constituent parts, and make another analysis, and so on and so on and so on. And essentially, this is how we've arrived at the medical system that we have today, which is a highly reductionist system, compartmentalization of the human body, such that you have all these different specialties and disciplines within medical science whereby the patient, individual patient, is chopped up into little bits and pieces instead of having someone having an integrated perspective on how all this fits together, right? So if you have a digestive disorder, you're going to be referred to a specialist, a gastroenterologist. And then there are subsets of different types of gastroenterologists that would help you understand different aspects. But there's typically at no point in that process as you're going through diagnosis and assessment is there someone reintegrating all that information for you so that you can make sense of it, because we know that your body is an integrated whole, and yet the way medical specialists would look at you is that you are just a bunch of little tiny parts, because this is typically what happens when people get on the so-called medical merry-go-round is that they get broken up into these little constituent parts and end up feeling like there's no one helping them understanding what the whole of it is and how it impacts their overall health, which is how we experience our reality. Like we don't experience our reality or disease as an experience of some constituent part. If you're in pain or discomfort, it's not like, oh, I've got some discrete pain in this area. You may, but it impacts and affects your whole being. It needs to be incorporated within the whole of that context. So we see it in medicine. We see it in many other applications as well, where modern technology has led to more complexity and unintended consequences. The fact that microplastics are found in the most remote parts of the earth, in the Mariana Trench, found in the upper levels of the stratosphere. We find microplastics in organs in our brains. Nobody was thinking about this 50, 60 years ago. I mean, there might have been some people for sure. I know there actually were, like BPA as an environmental toxin, as a xenoestrogen as early as the 1930s. And yet that didn't stop anybody from limiting our exposure to xenoestrogens. So there's all these kind of unintended consequences. Of course, when we involve the economy and financial incentive, then it gets even more problematic because there's no incentive to step back and take a look at the whole while you just mindlessly pursue a specific advantage over another. Once again, predicated on this notion of the law of identity, that you're going to choose one thing over another and not see the interrelationship of these different elements or components. So microplastics, nuclear weapons, environmental degradation, none of these evolved with the intention to create these unintended consequences. These unintended consequences arose because we didn't fully appreciate the object of our pursuit. And this isn't something that is absent from science. There is something described as the precautionary principle, which is to say that whatever technology that we're applying, that we want to make sure that we are very careful in its application so that we can be mindful of these unintended consequences, be prepared for them, even for those things that we don't even know that might happen, that we have a way to recognize and deal with them so as not to create a great deal of harm. We're also right now on the precipice of that with artificial intelligence. I don't think any of us have asked for this incredible investment and emphasis on artificial intelligence. I think, some of us benefit from it for sure. But of course, there's a huge financial incentive, and the whole notion of precautionary principle has been completely tossed out. But even prior to AI, just look at the introduction of things like the personal computing device or the mobile phones. This has been talked about extensively by social commentators such as Jonathan Haidt. For example, the impact in 2012 of the launch of the iPhone, such that, now most teenagers have an iPhone and they're scrolling through Facebook and Instagram, all the different social media apps. We didn't think about the consequences of having children who don't have the maturity to self-regulate, giving them this incredibly powerful computing device in their pocket that they could use to essentially create a sense of disconnect, not intentionally, but that's the result of it, such that they end up feeling lonely, isolated, and depressed. And hence, you see since 2012 an incredible spike in teenage depression and suicide. And I think many of you, I probably don't need to give you too many examples of that. I'm sure you have an understanding and examples in your own life of people, young people in particular, that have been profoundly impacted by the introduction of this technology without any safeguards, without an appreciation for the unintended consequences, without applying that precautionary principle. And we're dealing with that as a huge social issue, and we're now jumping on the bandwagon of AI. We're probably just a few years away from general artificial intelligence, where we're no longer going to be able to control AI. We barely understand LLMs now, how they function. And, in a few years, we're going to be having these general artificial intelligences, these different models that are able to understand and synthesize information in ways that we are not able to, that are beyond our capacity to understand, and essentially putting at risk the future of humanity and the earth, all seemingly just because it's financially advantageous. Right? Like if you invest in AI stocks over the next 5 years, you probably make a lot of money until the AI takes over and then, delivers some bioweapon and wipes out the population. I hope that doesn't happen. I'm not rooting for that. But unless we step back and we appreciate these unintended consequences rather than this relentless pursuit of technology, we are writing our own tombstones. Now, of course, implications for human health, this notion of compartmentalization, that we could apply something like artificial intelligence and not think about the unintended consequences on the economy, on people's psychology. We also see that in medicine. I referenced that earlier about how how we tend to compartmentalize a patient into different data points. I don't know if many of you have had this experience, but there was a time several decades ago when you saw a doctor for an appointment where they sat down, they looked in your eyes, they maybe took your blood pressure, they looked in your mouth, they palpated your neck looking for swollen lymph nodes. They did a number of different types of physical exams. They talked to you to get some understanding of what might be happening. And now, in many cases, when you see a doctor, and I have a lot of sympathy for doctors, but they spend more time on their computer typing away at the keyboard, inputting data, just asking you questions instead of sitting with you. And instead of focusing in on your experience of imbalance or disease, they're looking for different surrogate markers. So you won't hear me complain about the utility of blood tests. I think they're really helpful and important, and I look at them, but they're not an accurate representation of the whole. They just give you insight into usually just a little snapshot. If you look at a blood test, it's just literally a tiny snapshot of what's happening in the body at that moment. And it's really scary to think that people get diagnosed for a particular disease with just one blood test. Like if you have a thyroid disorder or there's some concern that you might have a thyroid issue, you go and you get your TSH tested, which is a surrogate marker of thyroid function. And whether it's elevated or whether it's low, a diagnosis will be made and then treatment provided. At the very least, it would make rational sense to undertake that test several times so that you could graph it and you could see if there's some type of trend line. Because we know something with TSH that it has a diurnal secretion. It goes up, it goes down, depending on the time of day. It can change if you're a woman with your reproductive cycle. It could change according to the season, your stress pattern. So it's very difficult to make an accurate diagnosis on the basis of just one blood test, but that's exactly what happens. You go and you get a lipid panel, your LDL is elevated, boom, you're on statins. And not only is just undertaking a treatment on the basis of one blood test exceptionally problematic, but then when we delve into these different markers of imbalance, we see that they end up being rather inefficient and sometimes inaccurate. For example, 50 years ago, people would get their serum cholesterol level tested, and if their serum total cholesterol was elevated, then that was hyperlipidemia, and then some type of treatment was provided. And we discovered that that's not a very accurate reading. In fact, you can't correlate elevated cholesterol levels with an increase in morbidity or mortality. For example, look at stroke risk. We found that people that had higher than normal levels of total serum cholesterol actually had a protection against stroke. That the people that had the lowest levels of serum cholesterol had the highest risk of stroke. Taking the whole model of dyslipidemia and putting it on its head. And so then it was decided, okay, well, we're gonna refine this model. We're gonna compartmentalize further. We're now gonna look at LDL and HDL, the so-called bad cholesterol and the good cholesterol. On the basis of those readings, will determine whether or not you're at risk. And we've understood over time that those are also not accurate markers. Now, of course, when a patient comes to me and their LDL is elevated and they seem like they might be otherwise metabolically healthy, like maybe depending on dietary factors, maybe they eat more saturated fat than other people. They're on more of a low carb kind of ketogenic type diet, which I'm not a big fan of the ketogenic diet per se. Low carb is fine. That I will say, well, let's refine that further. Let's look at your LDLP levels, the particles, because we know that the large foamy LDL particles are not atherogenic like the small dense ones, and so it's good to get that reading further. But I know that any of these markers that we're using don't give me the whole picture. I have to be able to step back and integrate them within the whole. And that's not something that typically a doctor will do. And certainly, if you are seeing a specialist, they won't do that. They won't do that. They will just focus in on the diseased organ or tissue that they specialize in and not understand or appreciate its interconnection with all the other different aspects of the body. And this wouldn't be so bad if the fact that the types of medicines and therapies that we use typically have very narrow therapeutic windows of applicability. So drugs that we use, they have to be targeted to a very precise dosage. If that dosage is just a little bit too low, the medicine isn't effective. If that dosage is just a little too high, it can be very toxic and life-threatening. So it's very difficult to get that medicine in that narrow therapeutic window. let's say you've got a ball and you want, you're standing against a wall and and there's a little tiny window and you want to throw that ball through that window. How many times is it going to take you? You mean you have to be kind of an expert uh, to do that, right? Or like say shooting a basketball, always getting it in. I mean, certainly some people are very good at that. But just imagine if you're dealing with a patient, that net is going to be at different positions. It's going to be at different heights. It's good. The size is going to change because none of us are standard. We're all different. And so, your expertise about shooting that basket or throwing that ball through that little window is hampered by the nature of reality that none of us exist as these objective standards. We're all unique. And that's also so the problem too with a lot of these surrogate markers and blood tests is that on the basis of a population study, basic averages for what those markers should be, but some people present as being out of range, and that's just normal for them. Some people produce a little more platelets than others, or maybe produce a little less of another substance, and it's not necessarily pathological. The only way to understand it, though, would be to step back and understand it, integrate it within a holistic perspective. So this also represents a problem, this notion of these very narrow, limited therapeutic windows. And now, of course, what's happening because of this reductionist tendency, we understand that the theses and ideas that we have about diseases changes rapidly. And especially with AI, it's changing very, very quickly. So I came across a paper, I don't know, maybe it was like 15, 20 years ago that looked at the half-life of knowledge or clinical knowledge. So it said that at that time, there was about a 40-year half-life. So that if you're looking at a diagnosis and then a particular treatment for that diagnosis, that's the gold standard, that in about 40 years after that was first accepted and applied, that it's probably going to change and be flipped on its head and may end up being something that's directly the opposite. And there are actually many examples of that. We see that in psychiatric medicine. At one time, gold standard for treating hysteria was a frontal lobotomy. Nobody's recommending that nowadays. But to the extent that how they were applied in the past, it's shocking to consider how frequently they were applied and how many people were injured by those interventions, simply because of the sort of fundamental arrogance of the practitioners applying those therapies. So the half-life of knowledge is something that's really important. Another good example here is prostate cancer. For many years, it's the gold standard understanding of prostate cancer is that it was an androgen-dependent tumor, and therefore men that had prostate cancer should undergo some type of surgical or chemical castration to limit the exposure of the prostate cells to androgens. And intuitively, it doesn't make a lot of sense because as men get older, their androgen levels go down. So if their androgen levels are going down, why do we aggressively want to target androgen levels and reduce them even further if they're already trending that way? Because most men are getting diagnosed with prostate cancer, they're not, they're older men. They're men in their 60s and 70s. And in fact, most men by the time they're 80s have probably some degree of prostate cancer. It's in most men, it's a very slow growing cancer that probably won't kill them. But in some cases, it can be more aggressive. But the standard therapy is anti-androgen therapy. And recently, there's been a complete reassessment where people are actually using testosterone to treat prostate cancer. So the very thing that was discouraged, that was considered to be the cause of prostate cancer, is now being used in some cases to treat it. Now, hearing that, I want to make sure that if you know someone with prostate cancer, testosterone therapy may or may not be helpful. I'm just using this to illustrate a point that the half-life of medical knowledge means that information changes over time, Treatments can change over time, and sometimes it means that they end up being exactly opposite to what was originally articulated. So that paper I read 15, 20 years ago said the half-life was 40 years. It's now estimated it's probably less than 3 months. So whatever we think of as being a gold standard understanding of a particular pathology or disease, in terms or the treatment of that disease, it's probably wrong in some aspects. And because things are developing so quickly, for example, with AI, that it's likely going to be flipped on its head. And that's a little bit scary. It's a little bit scary when you think about all these different medical interventions that are available to you, that you find out in a few years that, wait a second, that was completely wrong. We had it completely wrong. We had this kind of groupthink bias happening. We all nodded and accepted, yeah, this is the way we should look at it. And then, in a few years, we understand that that was completely wrong, and we caused more harm than good. Now, that to some extent is just the nature of doxa. We live in this, changing reality. It's rather an inherent aspect of our reality. We can't get away from it. Right? So that's why we want to employ this precautionary principle. And I believe that this precautionary principle in science is informed by this holistic perspective. That we're cautious because we don't have the whole perspective, and therefore we need to be cautious because there's going to be things that we don't know, that are going to change. So let's be cautious as opposed to being incautious. What's also interesting too is that the philosophy of Aristotle's law of identity, of separation and reductionism, means that we can often apply treatments and obtain some degree of clinical success in some limited parameter, while in every other parameter, the health, the experience of the patient declines significantly. I remember many years ago, I was at my training. We went to the pathology lab at Vancouver General Hospital, and we spent some time hanging out with a pathologist. And we were going through the lab museum, and they had people's pickled intestines, people's different digestive organs that had been surgically excised, sitting in formaldehyde, looking at all the different disease structures. And we came to this section on the large intestine, and I suspect the pathologist was being a little facetious because we were all a bunch of herbal students. He said, you know what? I think that when people are born, they should just cut out their large intestines. For the amount of trouble that they cause people, just remove them and have a colostomy. That would be much easier. And of course, we were just wide-eyed and just like in shock with that statement. I think he was having us on a little bit, but it does reflect a common belief or perception in medicine. You'll see it, for example, like an understanding of the appendix. The appendix is a vestigial organ. It has no function or utility. And because it causes problems for people in the future, maybe we should just surgically remove it. They used to do that with tonsils, right? They would just line kids up in the 40s and 50s and just remove everyone's tonsils, because they thought the tonsils, they don't have any useful function. But of course, we now discover that the appendix is an important area that stores probiotic bacteria. It can help to recolonize the gut after infection. We know that tonsils play an important role in maintaining the immune function of the upper respiratory system. So all these vestigial or useless organs that have no function or utility, no, they do. They have some important applications and uses. And it really brings forth the Hippocratic oath that doctors supposedly are meant to adhere to, which is at the least do no harm, because I think a great deal of harm based on this reductionist model is being caused. The challenge is that we don't really understand it. We don't really record it. So there was a paper that came out around 2000. It was called Death by Medicine. The author, Gary Null, and his co-authors came up with this analysis of US healthcare and determined, based on the available data, that modern medicine was the third leading cause of death. Now, there was a lot of pushback and finger pointing when it came to this. Some people thought it was unfair. there's some unclarity around this simply because there isn't enough good information. But the information that we have subsequent to that paper being published in early 2000s, it seems that nothing has really changed, that indeed modern medicine is the third leading cause of death. And that primarily relates only to interventions applied in hospitals. It could be, hospital-acquired infections. It can be unnecessary or improper surgeries, but most often it's related to the adverse reactions to different pharmaceutical drugs given in a hospital environment. All of those together are the third leading cause of death in the United States, up there with cancer and heart disease. The scary thing about it, the thing that's not actually being calculated in those statistics, is what happens outside of a hospital setting. And the thesis of the Death by Medicine paper by Gary Null was that, in fact, if you consider all the different aspects of iatrogenesis, which is medicine-induced injury and death, it probably is the leading cause of death. And now, some people would say that's unfair. Like, you have a patient that comes in, they're already sick and unwell. You give them some medication, they had adverse reaction. Is it the medication or is it the fact that they're already unwell? It's a very difficult thing to unwind and ascertain because, we exist in a universe of dependent origination, as the Buddha said. Everything is interrelated, everything is interconnected. Certainly, if you have a holistic perspective, you understand that there's no one cause of anything. There's multiple causes for things. Right? Just look at anything in your life that's ever happened to you. There may be seemingly one initiatory event, but just think about all the things that had to happen for that one event to happen. It's clearly all interdependent, right? And so this is the case as well when it comes to medicine and adverse reactions. But at least using the tools that we have to understand medical error, iatrogenesis, in both a hospital setting and a non-hospital setting, we can understand that medicine is somewhere between the first and third leading cause of death. And at the very least, referencing what I said last week in the first part of the discussion of holism, at the very least, this should inculcate a philosophy of humility and caution in how we apply our approach to therapy. And unfortunately, that's just not the case. I spend a lot of my time in my practice helping to wean people off of pharmaceutical drugs that they should not be on. And it's not because I have a philosophy that is against big pharma or that I hate all pharmaceutical drugs or I don't see any role for pharmaceutical drugs. That's not the case. I've been practicing for 30 years, so I definitely see applications for different pharmaceuticals. But in most cases, what I see in my practice is that they should be a last resort because there's a whole bunch of things that we can do before we resort to those types of medicines, which have a very narrow therapeutic window to restore balance to the body, to restore health to that person. And a good example here are antipsychotic drugs. It's become a very much a trend that patients that are suffering from mental health issues are being put on antipsychotics despite the fact that they've never had a psychotic episode. And these are really hard drugs to get people off of. Because even if you pull someone off of an antipsychotic very slowly, you taper them off, it creates this neurological instability that can last months. And it means that moving forward in the future, that they could have all types of weird idiosyncratic responses to different influences. And it's very difficult to ascertain what the cause is. Well, the cause is these drugs given to patients off-label when they shouldn't have been on them in the first place. Another good example here would be the use of the statin drugs. Referenced earlier, the dyslipidemia or elevations in cholesterol and LDL. It is figured by medicine to be a pathological factor in the development of atherosclerosis. So you give the patient a drug to inhibit the synthesis of cholesterol, and that's supposed to solve the problem. It's based on the notion that the atherosclerotic lesions, which are mostly rich with cholesterol, are causative in atherosclerosis. But when you take a deeper analysis, you understand that, wait a second, cholesterol isn't necessarily a bad thing. I mean, the body synthesizes cholesterol for good reason. We use cholesterol to synthesize sex hormones like estrogen, testosterone, progesterone, cortisol. They're essential for endocrinal balance. We use cholesterol in the body to stabilize plasma membrane problems. So the covering of your cells is called a lipid bilayer. It's phospholipids. It has different fats in it. Many of the fats there are so-called essential fatty acids. And they're highly reactive compounds that can initiate the release of locally acting eicosanoids, which are basically like little hormones. And so if there's some type of influence that damages the membrane, there's like a chain reaction that happens across the membrane that destabilizes the whole membrane. And it would keep continuing and wrap all the way around the membrane to completely destroy that cell, if not for the fact that the membrane also deposits chunks of cholesterol in there. And it serves as a buffer. So you have this cascading inflammatory effect on the plasma membrane where all these fatty acids are being destabilized until it gets to cholesterol, and then cholesterol just stops it. The cell needs to know there's some type of injury and needs to have some type of response to it, but not at the expense of damaging the entire cellular structure. So cholesterol is a membrane stabilizing molecule. It's essential for counterbalancing inflammation. So why do you think there's so much cholesterol in those atherosclerotic lesions? Is cholesterol a causative factor, or is it a compensatory mechanism that the body is using to stabilize the inflammation of those lesions? And more research suggests that it is the latter. So if we're giving patients drugs to inhibit the synthesis of cholesterol, then we're actually inhibiting the body's ability to maintain and support health. And we are fingering the wrong cause of atherosclerosis. Now, let's say you're a caretaker of a 14-bedroom old dilapidated mansion, and the owners have said, well, I want you to go inside and I want you to make sure all those rooms are looking nice. And so you do that. You go to the first room, you scrape all the paint, you put spackle on there, you cover up all the cracks, you paint it, it looks nice. You move on to the next room, and so on and so on and so on. And then, 6 months later, you come back to the first room and you can see there's more leaking, and you're like, oh my God. So you apply spackle and paint it up again and do that process for every single room. And as you go through, you find that every time you come back 6 months later, it's degrading again. And you keep applying spackle and sealing off those cracks. Well, now just imagine if that was replicated, over 1,000 years, and you kept doing that, that room would get progressively smaller and smaller because of all of the layers of paint and spackle, plaster that you've been putting on those walls. So that's not the way to solve the problem, right? And moreover, solving the problem wouldn't be to stop the guy from going in there and fixing them in the first place. So if you think of the spackle as being like cholesterol, so you just like, okay, don't do that anymore. Don't put cholesterol in the arteries. Do you think that's going to stabilize anything? No, the problem is that the roof is leaking and we haven't addressed the leaky roof. So if we don't address the leaky roof, it doesn't really matter how much spackle or not we place in these rooms, it's not going to solve the problem. But certainly it will look better if we put spackle on, at least for a time. And that's what the body does. You haven't dealt with the fundamental cause of the arterial inflammation. The body is synthesizing cholesterol to deposit it in the arteries to stabilize the inflammation, but it's a stopgap measure. And the body would stop employing that if you dealt with the underlying original cause of that inflammation in the first place. But that is not cholesterol. Typically, it's glycation from eating a high carbohydrate, high sugar diet. It's chronic stress, it's smoking, it's environmental toxins, lots of different things that cause injury and damage to the endothelium of the vascular system, but it's not cholesterol. So just stopping the body's ability to synthesize cholesterol has all these unintended consequences. And that's why most people on statins are usually not on them for more than 6 months before, surprisingly, a majority of patients will end up taking themselves off of statins because of the negative side effects. So there's all kinds of unintended consequences we have from having an improper, highly reductionist, compartmentalized perspective on health, and we suffer from those repercussions. Okay, so looking at the time, I'm going to wind things up for today. Remember, if you want to join me for the Q&A All you need to do is go to dogwoodbotanical.com/subscribe and you can join. Otherwise, we'll see you on YouTube and on CJMP. Thanks for joining me today.